And start now at the count of three. Three, two, one, and we are live.
Hello, everybody. Greetings from Connect to Clinic, a digital conclave supported by Alchem. I'm Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania, Heartcare Foundation of India, Editor-in-Chief, IJCP Group, and past National President, Indian Medical Association. We are going to have an interactive digital feast today in the form of a conclave on an important subject, and that's Connect to Clinic. A disclaimer that doctors from all over the country have gathered together to discuss Connect to Clinic, which is a platform. Going back to the telemedicine guidelines and the Telemedicine Act, the government permits us to discuss any platform because the government itself writes in the telemedicine guidelines, you can use WhatsApp, Twitter, and it talks about all the trade names, Google, Meet. So it gives us, because all of them are brands, so therefore it becomes important for all the doctors to collectively discuss on a or multiple platforms to see what is there in it which is beneficial to us. And it becomes our important as specialists and key opinion leaders in the country to share our experiences with thousands of people. I've been told over 5,000 people are going to join today. So we represent the collective consciousness of the whole medical profession in the country. We will be sharing our views truly to ourselves. And frankly, we will talk about our experiences on this platform vis-a-vis WhatsApp platform, Google platform, or any other platform. This session is important. Telemedicine is important. Probably this COVID virus has come only to tell us, look, your patient-doctor relationship is disturbing over the last many decades. Patients are not satisfied with you because you are not giving them enough time. You are giving one person more time, other person less time. People sit in your clinic, have a cup of tea, they sit together for half an hour, other patients get disturbed. He says that punctuality, according to our MCI rules, which is now NMC 3.3, that you have to be punctual. You need to inform the patients. You need to keep a record. So one of the factors now which has improved the patient-doctor relationship is telemedicine. And when we know that telemedicine can give a comfort to the patient and to us, and also it is saving a huge cost to the patient. If a patient comes and tells me today that I'm having a chest pain, I will immediately say, go to a hospital. I'm coming there. Once he is in the hospital, he is admitted, he is billed for 50,000 to 1 lakh on the first day. And when I'm doing it, now he says, I'm having a chest pain. I say, come to Connect to Clinic. He comes there, I see him, and I typically from a distance know this is a typical costochondritis and not a heart pain. So I avoid his admission. From a distance, I know a diabetic patient is in hypoglycemia. I just have to see, look at him. The same thing for which I had to go drive 20 kilometers, reach the emergency department and say this is hypoglycemia. Now it is possible at a click of a second. I just click it and I know this is hypoglycemia. I can order. Remember Three Idiots? The whole delivery was done using a app. The whole delivery, they showed us the way. And that has today shown us the importance of telemedicine. And today, our focus is going to be in diabetes and in cardiology. Both of them are bread and butters. Diabetic means diabetic nephropathy, retinopathy. We have diabetic skin, we have diabetic foot, we have diabetic neurology, diabetic autonomic functions, diabetic sexual dysfunctions, When it comes to cardiology, sky is not the limit. From chest pain to post bypass to PTCA to 6-minute walk test to blood postural hypertension, you can exactly ask the patient to demonstrate postural hypertension and see whether he's symptomatic or not. All autonomic functions can be done from a distance. Only the patient requires is a portable, which is a miniature ECG machine if they have, otherwise a SpO2 monitor and a BP instrument and a peak flow meter. With this introductory remarks, I will invite 3 speakers one by one. They will be sharing their views on a specific subject. Then there will be a panel discussion, and then there will be a question answer session between me and the technology with that. So first of all, I want to introduce Dr. Brian Pinto. I've always been one of his silent admirer. He is a MD with DM Cardiology. He's a Chief of Cardiology, Holy Family Hospital, Mumbai, Director, Cardiac Cath Lab, International Cardiologist attached to Breach Candy, Nanavati, Holy Spirit, Safi, and Hinduja hospitals, pioneer of transradial procedures in India, member of Cardiological Society of India and API, over 1,000 procedures, including rotablation, peripheral cases, currently EC member of CSI, recipient of William O'Neill Award of Cardiology, multiple research activities, published paper in many international journals. He will be talking about telemedicine, a new type of house call, a lifeline for cardiac patients and the cardiac physicians. Over to you, Brian.
Thank you, Dr. K.K. Agarwal. It's always a great pleasure to see you, to hear you. You've been inspirational for all of us, and we enjoy listening to whatever you tell us. Just now, when you spoke to us about COVID, it was so informative that we always carry these pearls of wisdom that you kind of tell us. And thank you once again to Alchem for having me on this particular aspect of telemedicine and telecardiology. Could I have the first slide, please? So here is what my book is about. I can take. Should I go to this thing? You can see me properly?
Yes.
Okay. And can you hear me well enough?
Yes.
Okay. So the brief is about looking at the facts for medicine and cardiology, the expanding role in cardiac care. And from the next slide, you will realize that this aspect covered in the Economic Times as well as in the Business Standard shows that we will be producing at least 65 million jobs in the next 4 or 5 years in the department of telemedicine. So you can imagine, to kickstart the economy, we could have telemedicine and telecardiology as one of the biggest factors that can bring in huge number of jobs. And as just been reported by Dr. Agarwal, it enables people to communicate across all geographical barriers. In fact, today I have an ECG machine in my clinic, which if I send out with anybody who just knows to put the leads on, I can receive that ECG on my phone immediately. And that enables me today to give a diagnosis in most patients, at least as far as the ECG is concerned. All the rest can be heard on the phone. So in spite of the fact that we can have an ECG done remotely and take it on a WhatsApp and communicate it, we can even have a better modality. This is by one of the companies called CardioScreen. And I know there are multiple modalities available today where you could have an ECG transmitted almost immediately. You can see that this market in India is going to go up to 5.5 billion US dollars by 2025. And that's not very far away, 4 or 5 years from now. And the post-pandemic has clearly shown us today, none of us sit, or majority of us don't sit in our hospital OPDs. You know that. And so many of the patients in our hospital OPDs are now communicating to us through teleconsultation. The patients have also grown more familiar with it. They are accepting of it, and they're accepting of the fact that they are able to get a lot of information, not only from their own doctor, but also across a brand of specialities. Next slide, please. So this is here to stay. Shrishti, the next slide. What we also see in this particular next slide is that, Shrishti, you forgot to get the slide on, you got me on. You having any difficulty with the slides?
No, sir. No, sir.
Yes.
Yeah. So here is the next slide that shows you how this has percolated. And one of the first things I would like you to see is the number of smartphone users in India, because it's not the computer, but it's the smartphone that is clearly transmitting this information so rapidly. Today, the number of smartphone users are 700 million, which is likely to go up to 1 billion in a number of 1.4 billion people. So you can imagine that the smartphone industry is possibly the largest growing industry in terms of devices. Computers have not been able to grow as fast, and this growth is showing us that the digital technology, how it is growing, the digital technology across by 40% is growing per annum. So you're going to get faster and faster digital technology, and very soon we're going to have 5G with us, which is going to transmit files so rapidly across, and films and so on and so forth, MRI films, CT scan films, so many of this will be transported so quickly that the market size is growing by 35%. And this is not going to stop in the era post-COVID. It's actually going to increase. So this is going to be the new normal, where a large number of doctors, and let me tell you one more thing, robotics has entered not only the surgical field, it has also entered cath lab. Today, you can sit in another place and perform an angioplasty. You know that. You can sit far away. I could sit in Mumbai and perform an angioplasty, maybe in Panvel or maybe in Gurgaon. This is the way we could have technology move. So it's not only a surgical procedure that can be performed, but also an angioplasty or a valve replacement. All of these technologies will become possible through remote handling in the next few years. Angioplasty already has become. Next slide, please. This is the growth story. Now look at the way in which the research was done. The research looked at what will doctors do after the COVID-19 pandemic. And here you can see only a very small number, just 7% said that this technology will not continue. However, 30% said in about 30% of patients, and 38% said in about 10% of patients. But I believe that this technology will continue to be there in a large number of patients after the COVID-19, because patients will realize, especially patients who are far away, who are more than 20 kilometers away from you, take 1.5 hours, 2 hours to reach your clinic, will prefer to have it done remotely. Remote is going to be the new normal, because that's the way in which the technology will save time, not only for the patient, but also for the doctor. Next slide, please. So telecardiology applications are very extensive in my opinion, and can occur far before hospitalization. I just told you about the ECG, but besides the ECG, the blood pressure, the home blood pressure monitoring services, the device monitoring services, all of this can occur not only in the cities, but in the rural regions. Just imagine a patient having a pacemaker who is not being recorded for years and years. They take sometimes their pacemakers fail in the remote villages because nobody is monitoring it. They could be easily monitored today with the telecardiology services that we have, and they can be told when to come to the city or when to come to the town for the next pacemaker change. They need not come and have their pacemaker checked every 6 months or every year. This is going to fasten the way and enhance the way in which we are going to treat these patients. Next slide, please. So what happens across for the healthcare workers in cardiac care? You can see across the continuum, whether it be hypertension, risk factors like diabetes, as mentioned by Dr. Agarwal, What about microalbuminuria? We can have all this tested. We can have it quickly on an application. You could have an Apple phone, or you could have an Apple device watch which transmits, or you could have another watch like a Fitbit that transmits. So you will have data that is getting transmitted across so quickly that patients who have their NT-proBNP levels done, that have their echocardiography done, will also transmit all this information. So you will get all this information transmitted to you at your clinic or at your house. And this will take away the barriers that impinge on success for healthcare services. So across the cardiovascular continuum, we can clearly monitor these patients and deliver better services to them in cardiac care. Doctors need not be going everywhere. It can be healthcare personnel that can go. Today, I send my healthcare personnel to a person's house to record an ECG. I do not need to go myself. I see it on my phone immediately. Even if I'm in my car, I can similarly see home blood pressure monitoring, which can be sent on my mobile device. This is all feasible and possible today because of a big jump in technology. Technology has made it a small step for the health industry to move a major step, as I will show you in the future, in the next few slides. Next slide, please. So these are the various benefits. You can see what I spoke to you already. Let's talk about the hub and spoke module that we can have for acute myocardial infarction. So, and Karnataka and so on and so forth. They have really jumped the gun because they have a remote service whereby a patient who is not close to a center which does angioplasty is admitted to a spoke module. And then he gets thrombolysis done over there because the ECG is well read already. The patient gets thrombolysis over there, and then within 24 hours time is transported to a center where angioplasty can be done. That in the future may not be necessary because the person can perform angioplasty from his center at another center, even if it's a complex case. Similarly, patients who have got many areas which need to be covered, for example, cardiac devices, teleconsultation for general practitioners, you need to basically update them. All of this and emergency cardiac services can also be conducted. There can be the future where a drone can possibly carry one of the devices like an automatic defibrillator. You have a situation of an emergency, you have a traffic jam, you cannot monitor, you cannot send, but you would be able to send a drone into the area very rapidly, and people who are trained in CPR can immediately deliver a shock where that information can go to them saying that this is a VTAC, this is a VFib, and you need to shock immediately. So telemedicine will also incorporate into the field the capability of taking care of cardiac emergencies, reducing mortality and morbidity significantly, and continue to monitor devices that are being implanted in patients and devices which are being used at home can be quickly monitored. Next slide, please. So what are the benefits to the patients? The patients can go across a continuum of specialists and across a continuum of hospitals. They need not be stuck to one area. They need a consultation in America. They need a consultation in Germany, not only for cardiac care, let's say for a heart transplant. They could have a great heart transplant surgeon give them a consultation, tell them about pulmonary artery pressures, talk to them about the RV, talk to them about the costs of surgery. And this can be available at the touch of a button. This is not available as yet, but it is getting there. Once it gets there integrated, you will realize that if you go to heart transplant, for example, you would be able to get a list of doctors who are doing heart transplants, and then you can talk to that particular hospital, find out about it. Also allow you to get to remote areas. Remote areas will not be so remote anymore. We do not need to just have remote areas and say that they are not covered. Primary care centers can be immediately incorporated even with doctors who may not be as specialized, but with the help of telemedicine can have all these diagnoses made, including the telecardiology diagnosis, and administer treatments like thrombolysis, treatments like defibrillation, all done both in emergency and outside of emergency. And this could be to a great extent reduce the expense to patients, reduce travel time, and allow them to get across a full board of medical specialists. Next slide, please. So telecardiology, you can see from various studies, have benefited. The improvements have happened in the various aspects. For example, the rate of readmissions, the rate of hospitalizations, all of these have gone down with telemedicine. Patients have been followed up for 12 months, monitored, given their treatments. Even patients who have had, for example, angioplasties done or who had devices implanted need not come for regular follow-up every month and things like that. They may come once in 6 months, and you can have them followed up. And these benefits can be seen across all populations. And this is a program whereby the hospitals can also implement these programs at a much better level so that the patients can benefit tremendously from these telecardiology and telemedicine services, which can be charged for, but at a much lower rate than when they come and visit the hospital. Next slide. So in hypertension management also, you can see that when you have, today we know that the guidelines still look at the single blood pressure recording in the office, or maybe 3 blood pressure recordings in the office. But all of us know that the ambulatory blood pressure monitoring and the home blood pressure monitoring is far more significant and far more reliable than the single office blood pressure monitoring. All of this can be done electronically through telemedicine, and the management of the patients can be done quite well, looking at the home blood pressure and the ambulatory blood pressure monitoring. And this can be communicated so easily that we can take on a burden like hypertension, which causes almost 10% of the mortality across the globe is caused because of hypertension, can be very well managed by this particular thing. Next slide, please. I have just a few slides left. So you have in cardiac device studies, you can see today it's a very big problem to monitor these CRT devices. People do not know how to do it. Even many cardiologists don't know how to do this thing. This can be monitored very easily. ICDs, cardiac resynchronization therapy can be easily done by telemedicine. Otherwise, the patient has to come, some specialized person has to come, or a specialized EP person has to come. This can all be completely made unnecessary and can be completely eliminated. All of this can be monitored remotely. The findings can be given, and this can make it much easier for follow-up for these kind of patients, where much fewer EP fellows and things are available. Easy to follow up, easy to keep records of. And this management studies show that the success rates have been in the region of 90 to 99%. Next slide, please. Cardiac emergency also has a great benefit. Studies from Italy have shown that in cardiac emergency services, if you have patients who you can treat with the medical health workers and not doctors, they can administer thrombolysis, they can do defibrillation, so long as they are connected to a port where there is a cardiologist or where there is a emergency care physician, and all this can be done at a much reduced cost. Most of you know that when thrombolysis is given in the ambulance or in the home before the patient reaches the hospital, that is the best way to fibrinolyze patients. It's the best way to get the best results in acute myocardial infarction. And today, with COVID on board, all of us have turned back. No longer are great cardiologists talking about PAMI. All of them are running away from PAMI because you may have a COVID patient over there. So what we have gone back to is the pharmacoinvasive therapy of giving thrombolysis first and then waiting for the patient to stabilize, then taking him to the cath lab. Otherwise, we all have to wear PPEs from head to toe, making it a very cumbersome procedure. So the transmission of the ECG has become a very important role in this particular area of ST elevation and non-ST elevation myocardial infarction. Next slide, please. So this is the future of cardiology. I can clearly tell you not only the future of medicine, also the future of cardiology, so that we can be better preventive management people, we can be better treatment, we can have better emergency managements, and we can have better monitoring of devices. Next slide, please. So this is actually the end of my talk. The next one is by Dr. Jayanta Kumar Panda, and I think Dr. Agarwal will introduce him. But thank you very much for your attention, and I hope I could cover some of the aspects of telecardiology and telemedicine. Thank you.
Thank you, Dr. Brand. It was a elaborative talk. Actually, we need one full conference, 8 days, only to talk about cardiology and telemedicine, and which he has covered in 20 minutes in a beautiful way. Remember, it reduces travel time, reduces time of the patient, time of the doctor, gives you satisfaction, improves patient-doctor relationship. So there is no way that telemedicine can go out. When I was talking to the coronavirus last night in my dream, so I asked him, "Are you going to leave?" And he said, "No, I'm not going to leave. The time you say I'm leaving, I'll come back with a new strain." So therefore, the fear of corona, when H1N1 hasn't gone for the last 2009 to 2021 now, nearly 2021, this virus is not going to go. New viruses will come. So telemedicine is going to stay. Now we are going to listen to the same telemedicine in relation to diabetic clinic at a distance. Now, diabetes and telemedicine are synonymous with each other. You cannot afford not to work on a telemedicine as far as diabetes is concerned. The patient will not come back every hour and inform you about the insulin levels, about the blood sugar levels. So whether any type of a complications you should be able to see. I have with me Professor Jayant Kumar Panda, a close friend. He is MD in internal medicine. He is a professor and head PG Department of Medicine, SCB Medical College, Cuttack, Odisha. He has 22 years of experience, member Faculty Council, Indian College of Physicians, National Treasurer of Research Society for the Study of Diabetes in India, advisor to Government ACP India Chapter, Governor ACP India Chapter, member Executive Committee Diabetes India, National Coordinator for Certificate Course of Diabetes, and so many other things. He is also an advisor, Students Union, SLN Medical College, Odisha. So over to you, shift from west to the east. So let's see what the east is doing in telemedicine. Over to you, Dr. Jayan.
Thank you, sir. Thank you, Dr. Agrawal, for that nice introduction. And after the talk of Dr. Bian Pinto, you must be convinced about the benefit of the telemedicine in the practice of cardiology. I'll be telling you in brief in diabetology and what we do in the East, as Dr. Agrawal has already pointed out. You know, if you ask me, for last 25 years, I use telemedicine for my patients. Say it be a patient of infectious disease, say it be a patient of metabolic disease, we find it very comfortable, economic, and very affordable for our patients to go with telemedicine. I'm giving you an example already told by Dr. Agrawal. For minor problems like blood sugar adjustment, you want to adjust the insulin or oral drugs or monitor the lipids, blood pressure, that can be easily done without any physical contact with the patient. And if you're taking a tele session, it's not only affordable, it saves time of both patient and the consultant and becomes much easier for them. So with this experience, I'm taking you through the slides. If you see the diabetes patients, they have to take lifelong treatment, and not only diabetes, hypertension, dyslipidemia, macrovascular complications, microvascular complications, and many other issues they creep in. So a customized virtual clinic, which includes excellent audio video interface, facility to upload reports, and telecommunication with the help of telephones, emails, and the internet using a secure HIPPA compliant website, portal, or app. And the telemedicine enabled customized empowerment, education, and 24/7 patient counseling support, and ensuring multi-drug compliance in the diabetes. That is, for the multiple problems are very important in diabetes practice. And if you ask me, in the diabetes practice only, this becomes very essential more than other specialties. Next. So let us see what is the challenge in the patient with diabetes. I have already told it's chronic disease with stigmatization. Patient in all age groups with the NADI in the middle age, and the quality of treatment depends on the physician-patient interaction. Patient has a lot of expectation that the physician will help him getting over the complications, getting over the crisis. Around half of the patients have depressive symptoms because of a prolonged illness and association of complications. And self-monitoring of the blood glucose is the main step of diabetes treatment, because all the time the labs and the physician will not be available near the patient, and the documentation is integral part of the self-management. The compliance for the documentation is the key diabetes treatment, extremely costly disease due to the treatment and the complications. If you see, average the patient spends in India around 8 to 10,000 for the control of diabetes and complications. Next. So with this background, let us see the opportunity for teleconsultation in diabetes. When people with diabetes develop a viral infection, it can be harder to treat due to fluctuations in the blood glucose. With COVID situation, with the challenge of the COVID, we have seen how diabetes worsens the prognosis, and the patients have fluctuating blood glucose with steroid therapy, with stress, with multi-organ failure, and possibly the presence of diabetic complications. The teleconsultation help reducing chances of infection by reducing exposure to the hospital and the external environment, because patient did not come to the hospital. Hospitals became unsafe places few months back, and we saw the disease spreading in the medical wards. So we have a practice of screening every patient before hospitalization. Risk of a fatal outcome from COVID-19 is up to 50% higher in people with diabetes. Treat them from the security of their home through teleconsultation. They are at home, need not come, and at the same time that their diabetes is controlled. If they come, there is a chance of COVID infection. If they don't come, the chance of diabetes complications. If we see the ADA recommendation, the researchers tell up to 61% of newly diagnosed diabetic patients report a fatigue as a symptom. And we have to help them to avoid long travel and wait a long time in your clinic, putting inconvenience to you and themselves. The elderly patients' treatment can be secure and hassle-free through teleconsultation. Transportation of whom is an issue, taking them to the vehicle, again bringing them to the clinic and waiting for a long time. And the follow-up consultations through teleconsultation can reduce the overcrowding at the clinic, reduce long travel time, reduce the cost burden. And you'll not believe, it's very well accepted by my patients, very well. The patients know the doctor is not intending us to go to him. Doctor is not intending to make us spend for the investigations and the consultation every time, and doctor is helping us in controlling the disease sitting at our own home. And that gives them the confidence that my doctor is a good doctor, and they follow your words very strictly. Provide reach to remote places where there are no experts of diabetes. You see, India is dominated by the villages, and many villages, either there are no doctors, there are quacks, or there are some Ayush doctors or the pharmacists practicing. They are a complications, and the control of the blood glucose becomes an issue. Next. So with this background of opportunities, let us see the benefits of using telemedicine for our patients of diabetes. If you see diabetes scenario, I've already told how in a chronic care challenge, the telemedicine becomes useful. The research conducted on the effects of telemedicine on the blood sugar levels revealed the patients had a very well control. The A1C went very low. The LDL was controlled. I'll show you the study. And there is improved access to the healthcare facility for those living in the rural areas. When you need to go personally, you think that I have to take an appointment, I have to travel, I have to book a ticket. And during COVID time, the chances of infection at every place. But here, they just connect, and majority of time from a phone, and more convenient because of the reduction in the elimination of the travel time and the cost improvement. The patient is provided the counseling with a nominal cost of digital consultation, and he gets a time to interact with the doctor, and then there are issues which can be sorted over discussion in a teleconsultation for a diabetic. Next. So if you see the benefits, the support for lifestyle modification is very important. Counseling is very important. How the patient is taking insulin, whether walking or not walking, what type of diet the patient is taking, what type of food care, eye care the patient is doing. And the ADA reinforces this, that study, patient can be enabled to lose weight, lower their blood pressure, engage in healthy behavior to curb diabetes with the aid of digital health tools, where we can ask our educator, counselor to be connected with the people and advise them. We are doing that for the last 25 years in our institute, in our clinic. And here during COVID time, as Dr. Agrawal told, the COVID gives us a clear message: go virtual, go digital, and win the love and the confidence of the patients. The patient engagement, you will see, it provides a telemedical experience, which the rural patients with digital access to the medical support from their own homes, aiding the removal of the location barriers in the treatment, can take participation. The preventive programs like thorough digital access, rural patients can be provided online education materials to assist in the preventive measures. You can use WhatsApp, you can use email for that. The cost control, it can be more affordable, and patient need not spend every time for traveling, for consultation of the doctor, for lab tests every time unnecessarily. And whatever they do at their place is more accepted, and that can be shared with the doctor, and they can take the advice to get their disease controlled. It's very convenient, open access to more patients, secure and the private, and there is no decrease in the no shows or the cancellation, because patients very meticulously wait for the moment to get connected with the consultant. Next. So when you see such a beneficial effect, there are still few issues which are the challenges in telemedicine in the diabetes care. There will be situations like Dr. Agrawal told, a hypoglycemia can be suspected and be treated in the teleconsultation. But suppose somebody, you are thinking of a diabetic ketoacidosis or hyperosmolar hyperacidotic state, it's very difficult to establish and they manage them, which are the ICU admission requirements. So the communication error happens at times. Inefficiency to respond to the questions, unavailability of the physician. At times, the patient get frustrated, failing to consult over phone. It can be provoking to the patient. Rigorous and continuous training and supervision of the multidisciplinary team are required to ensure quality and expertise answering of the queries. Patient has to take a minimum digital orientation. Of course, the children nowadays are more aware than the parents and the grandparents, and they may help the parents and grandparents to get connected. That is a more practical solution. Despite the multiple benefits, patient may not be willing to pay extra for the teleconsultation. At times, the patient requires half an hour more for the issues the patient is having. But to the most important message goes, the patient at times become reluctant, but it hardly matters for the consultant. Even the slightest error in communication, suppose a drug is misquoted, not taken properly, so this can result in a complication, can result in serious consequences of poor blood glucose control or a side effect. So patients in India are conventionally used to the physical visit. They come to the doctor, see the doctor by face. Doctor needs the patient to touch the patient's hand, examine the pulse, and patient gets satisfaction. So old people may think of that, and receiving treatment advice only in a distant consultation may not make them completely happy. At times, that situation may arise. Next. So finally, I'll show you some case study, the benefits of the telemedicine in the diabetes management, and end my presentation. This is the enhancing diabetes care through the care coordination, telehealth, and education rural pilot program from the University of Alabama. And if you see the retrospective program evaluation in 12-month pilot diabetes care was done, and chronic care model and the trans theoretical model were taken. In the primary care practices, charitable care clinics and the rural health centers were connected, and the purposive sample had taken 106 referral form clinic sites and 59 patient enrolled, and interventions were the care coordinations, the telehealth, and the diabetes education. Next. So with this, let us see the patient satisfaction. The question was use of video in telemedicine. You see, 79% were very satisfied and 21% satisfied. When the question is the instruction of the medications and education, again, 71% very satisfied and 29% satisfied. If you think of not satisfied or somewhat satisfied, it's 0%. And specific questions like previous visit to the diabetes specialist, majority had no. Could explain the medical problems, 100% told that we could explain to our doctors. Satisfaction with technology versus face-to-face visit, 100% were satisfied. The privacy protected, 100%. Satisfaction with the physician communication, 100%. Video visits save time, 93% tell yes, 7% no. Video visits save money, 92% say yes. Convenient, 100%. Involved in the care during the telemedicine, 93%, and the recommended telemedicine to the family and friend is 100%. So you see the level of satisfaction. Most of the people are satisfied, their purpose is met, they have taken the right advice, and they want it to promote to their friends. And this is not a study from Alabama that I am quoting. This is my personal experience. We also published a couple of papers, but at present I don't have that slides with me. But the East India experience, especially at SCB Medical College, we started telemedicine almost 25 years back. We initially took advice from All India Institute, PGI, SGPGI, discussing our sick patients. Then we were connected to all the district headquarter hospitals where the doctors consultant. Now, during the COVID time, it is converted to the patient consultation. And this has been immensely used from the morning to evening with all the specialties. Why only diabetology? By cardiology, by gastroenterology, by the surgical disciplines, and patients are immensely satisfied, and the telemedical care is a huge successful model in the state. Next. So I have a couple of slides I'll complete. I'm just telling you in nutshell the benefit. It's not that the patients are happy. See the A1C. Yeah, just 2 minutes, sir. Just last two slides are there. So A1C will see pre-program was 10 and post-program 9.2. Total cholesterol came down, the BMI came down, the systolic blood pressure came down, diastolic blood pressure came down, and the DSME score came down. Next. So if you see the results are beneficial for almost all parameters. Next. Go back. Yeah. So next. Yeah, just the slide before. Yeah, go. Yeah. So this is my last slide. There are little gap in the current offering in the market. There are limited doctor-centric platforms. There are limited ability to stay in touch, reduced loyalty of patients, hidden charges at times, and the data security challenges. So I'll be concluding by telling you, you choose a platform which is convenient. And my experience using Connect to Clinic is very, very rewarding. Here, you'll have 100% satisfaction, and these challenges and issues are almost not there. And in a situation like a chronic disease of diabetes, most of the complications and the blood glucose control targets are achieved by the telemedicine. This is from personal experience. Thank you, Alkem. Thank you, all the panels, for the opportunity, and I'm sure you all will extrapolate such a technological advanced benefit for the treatment and get the confidence of your patients. Thank you all.
Thank you, Professor Panda, for a beautiful presentation on diabetes and telemedicine. You cannot think of Agra without Taj Mahal. You cannot think of diabetes without telemedicine.
You can call Aarti.
And when you go to East, you cannot think of East without Professor Panda. So coming back to the next lecture, before the next lecture, I want to read out one Supreme Court judgment. And I wrote maybe in 2009, I wrote about it. Can a cardiodiabetologist give a telephonic consult? This is 2009, much before the Telemedicine Act came. Indian Supreme Court judgment, Martin F. D'Souza versus Muhammad Ishfaq, 3541 of 2002, dated 17th February 2009, Justice Markande Karzu and G.S. Singhvi enlisted precautions which doctor, hospital, nursing homes should take. 54B. No prescription should ordinarily be given without actual examination. The tendency to give prescription over the telephone, except in an acute emergency, should be avoided. Now, here came a Telemedicine Act. So what is, if I have to read this Telemedicine Act with 54B, I have to read both the thing together, otherwise somebody will challenge it in that act is ultra wire. Then I have to make an established relationship. So if there is an established relationship between a patient and a doctor, telemedicine is allowed. So Telemedicine Act read with 54B, I need an established relationship. To establish a relationship, it has to be a video consultation which is recorded and which is available to you for a in future I should be able to take out, for which I need a platform. So without a platform, if I do this, except in emergency, if it is an emergency, do what you want. So the Supreme Court very clearly says, except in emergency, you need to have an established relationship with the patient, and that established relationship is incomplete without a platform. Let's talk about now the overview of Connect to Clinic, current and future offering of C2C from the horse's mouth. And I will also be thanking both Dr. Pinto and Dr. Jayant Panda, because both of them may leave in between if the program gets delayed. Otherwise, we'll love to have you in the panel discussion. So Dr. Ganesh Ramachandran is a digital transformation leader who has helped set up, grow, and turn around businesses. He brings over 25 years of experience. He has been a part of the CIO Power List of 2020, awarded the best CIO in 2023, brings exposure across diverse industries, including many things. He's a Six Sigma Black Belt, a strength certified coach, and a lead auditor for information security. By qualification, he is an engineer and MBBA and an MBA. So over to you, Ganesh, in fact, you should have started, because you always start good function with Lord Ganesha and Ganesh, but we are ending it up, the discussion with you. So Ganesh, over to you. He is the Chief Information Officer to present on the platform.
Thank you so much, Dr. Agarwal, for the kind words and for the excellent moderation. Thank you so much, sir, for being part of this and for making this a wonderful event. Good afternoon to all the people who've joined this session, and thank you for taking the time to be here with us to see how telemedicine can be used in your cardiology and diabeto practice. Both Dr. Pinto and Dr. Panda had laid out very nicely what the challenges, the opportunities, and how you could use teleconsultation and telehealth for cardio and diabeto. When we looked at this back in March, just as the lockdown was getting started, and we went and spoke to our doctors and said, what is it that you are looking for? What are the big challenges that you are looking at? What they told us echoed many of the things that you heard both from Dr. Pinto and from Dr. Panda. Doctors told us that they were very concerned about how they would engage their patients, because patients were now afraid to come to the clinic, which meant they were not sure how patients would manage their health better, and how could doctors make sure that that association that they have with their patients continues on an ongoing basis. Second, they said that many of the platforms that are there are virtual marketplaces, whereas what they were looking for was a way by which they could hold on to their patients and make sure they had a virtual clinic which enabled people to kind of come through and consult them and make sure that they stayed healthy. That's how our journey started. Somewhere around April of this year is when we started this journey in Connect to Clinic. We launched our first version in June of this year. And we were very clear, this was supposed to be a platform for doctors, and it was done with doctors in mind. So what we were really looking for was to make sure that we had a way for doctors to say that this is something that I need as part of the features, and a platform that constantly keeps evolving. So we launched our first version of this platform in June with about 76 doctors who were really the people who checked out the platform for us and who guided us on saying what are things that the platform is okay with, what more do you need to be developing. June and July went in this pilot study, and the pilot that we were working and testing features out with the help and the active participation of these 76 doctors, to whom we are very, very grateful and thankful. From August onwards, every 3 to 4 weeks, we've been launching new features on the platform. And today, I'm happy to share with you that we have over 22,000 doctors on the platform. Over 6,000 patients have consulted using Connect to Clinic. And for us, what we see as critical in all of this is make sure that both the patient and the doctor are happy with the experience. So we do have a 24/7 call center as well, and strong ratings which check whether patients and doctors are getting a good experience out of it. And we've been consistently rated 4 on a scale of 5. Srishti, if you could move to the next slide, please. So what exactly does Connect to Clinic offer for you? You did hear doctors mentioning just before my discussion now about how important it is, not just for teleconsultation, but also for patient engagement. That is what Connect to Clinic offers to provide you as a one-stop solution for managing your practice better. It provides you a way by which you can conveniently set up a virtual clinic for yourself. What that means is when you send the link to your patients and the patient goes and looks at it, they will not see other doctors. They will see your virtual clinic only. All of this is done very simply because that's what we heard doctors telling us. You have a simple way to log in using just your mobile number and an OTP that you get through it. For both the patient and the doctor, this is the way you log in. For the doctor to sign up, there is a process as per what the telemedicine guidelines have been laid out. And there is a sign-up process, which as well we have tried to make as simple as possible, which the Alchem sales team as well enables you to help getting through with it. Security is something that's been a huge area of concern for doctors to make sure whether whatever information is being shared by their patients and by doctors with their patients, is it unique only to both of them? The platform enables that and makes sure that all the AV components and the infrastructure that's being used is HIPAA compliant and PCI DSS compliant, which is what you have for the payment gateway, because payment and financial transactions as well are happening here. And of course, all of this adheres completely to the telemedicine guidelines that are there. There are also a few features that we heard doctors asking us for, which are industry first as what we see in a platform. Some of those, and I will talk a little more, maybe a minute down the line, but a couple of them I'd like to highlight here, is that you get your payment settlement 24 hours after the consultation is done. You have an opportunity, just like you have in your offline clinic, to set a regular slot and a follow-on slot with both differing timelines and differing fees that you may want to charge for it. This is what we started with. What you see on the left hand block is what we started with in June, July, August, until September, October. That's all that we had. But increasingly what we heard from doctors was telling us that, hey, what I need is to be able to engage my patients. What do we mean by that? What they meant, what doctors were asking us was, they said, I need to be able to deepen my relationship with patients. And like Professor Panda so rightly pointed out, how can I make sure there is a continuous way I'm engaging to take care of the better outcome for the patient? So we looked at a way by which a doctor could stay in touch with the patient by providing nuggets of information, by providing reminders to the patients. And this helps in ensuring that the patient also is able to manage their outcomes better. So in effect, what Connect to Clinic provides you is a holistic digital platform to manage indications better for the patient. And we also provide what we realized very clearly, like you've been hearing from Dr. Pinto and Dr. Panda, is that patients are still getting used to this concept of telemedicine. In some places, they are more familiar, many are not yet. So how do you really build a way by which you're getting services across for doctors to reach out to their patients and say, how can you now reach me at my virtual clinic? I'll talk a little bit more about this as we go ahead. If you could go to the next slide, Shrishti. So a little more about the patient engagement module, because many of you would most likely be familiar with what teleconsulting offers, and there I will talk a little about what we've got here. But on the patient engagement module, which is an industry first that we see, what we do have on the platform is two things that we are looking at. Before I come to that, what was the objective that we heard doctors and patients asking us for? What they asked us for is a doctor said, I want to deepen my relationship with my patient, and patients are looking for that. Many of them are very concerned in the current times. Due to COVID, there is stress, they are worried, they are not able to come. So how do I keep sharing best practices and keep telling them that, hey, I am there for you wherever you are. You don't need to come to my clinic, but I can make sure that you stay healthy, and I'm monitoring your health. What that also meant was they wanted smart reminders to be sent to the patients post the consultation. From a patient perspective, they really wanted to make sure that they felt that the doctor was there for them at any given point in time. So what the key components that we have brought out as part of the patient engagement model are twofold. One, education. So there are curated content that is available on the platform depending on your practice doctors. And you could choose to pick up any of those areas that you think is relevant, whether it be an infographic, a knowledge nugget, an article, a video, and send that across to your patients with a personalized message that you can add on top of it. On the smart reminders, you can send reminders to patients for doing any tests that they need to be providing, reminding them of a follow-on that they were supposed to come for and see you. Both of these, from what we have found in our research, are ones that are highly appreciated by both doctors and patients to make sure that the overall disease management is a lot better. Shrishti, if you could move to the next slide, please. So just a quick summary of what is it that Connect to Clinic provides you. Dr. Panda was very nice to say that Connect to Clinic is a platform that he has been using and he's seen benefit of it. Just to sum what the benefits are that you would see as well as you start getting to see the platform. For one, I did mention that it is completely secure. Any information that is exchanged between the doctor and the patient, no one else can see it. Not Alchem, not Connect to Clinic employees, no one sees it, only the doctor and the patient get to see it. The AV components and infrastructure is HIPAA compliant, PCI DSS compliant, and adheres to telemedicine guidelines. You have an enhanced audio-visual experience. There is an e-prescription that is there, and you can also get to see the history of the patients who visited you virtually. It is compliant with the telemedicine guidelines, as I was mentioning. You also have the entire patient engagement module feature, which is not mentioned out here, but which I spoke about a little earlier. You get the consulting fee disbursed for you within 24 hours after the consultation is done. And like I was mentioning, you have a variety of slots that you could pick up depending on what you think is relevant for your consultation. Do you need a 15-minute slot, a 30-minute slot, or a 60-minute slot? Do you want to set a varying timeline depending on whether it's a first-time consultation versus a repeat consultation? So if you choose, you could set a 30-minute for a regular consultation and a 15-minute for a follow-on consultation with different fees for both of them. You could also send auto reminders to the patients, like what I was mentioning earlier. Shrishti, if you could move to the next slide, please. So like I was mentioning, Connect to Clinic is an evolving platform. And how is it evolving? We take feedback from the people who are using it. You are doctors. What we've already kind of delivered are some of the things that you see on the left-hand side. So for instance, doctors have told us that I've taken a 15-minute slot, but I do see that the patient has a few more things that he's asking me. I can't end the slot abruptly. So can I extend the slot on the fly? That feature has been enabled if the doctor does not have an appointment coming up next. Second, what happens, and in India, we do know that internet connectivity is a problem. And particularly in the pandemic times, we've been seeing that connectivity is very, very varying. It fluctuates. So what happens if you suddenly lose your connectivity? You have started writing a prescription, an e-prescription, and connectivity goes. What happens in such a scenario? Not to worry. You do have the auto save feature, which is there, and whatever you've typed in on the e-prescription does get saved automatically. Even if you have not been able to finish writing up the prescription and your consultation slot is done, you still have about an hour post the consultation by which you can make sure that you would write or modify an existing e-prescription before you send it to your patient. You can also see all your financial inflows for whatever virtual consultations have happened on the platform right here. And you have a complete 360-degree view of all the patient history as you scroll down and see it on the platform. That's what we already have. A few of the others, and this is coming to you soon, but some of these are already there, like the curated platform content is already there now. So since the time the slide has gotten made, which is about a week to 10 days back to now, you do have this feature already available. You also can sign up for webinars that may interest you, which comes on the Connect to Clinic platform. We are also looking to build out a three-way audio video facility. And we've heard many people telling us this, that I want to get my mother or my father or some near and dear to virtually consult a doctor, but they are not very comfortable with using a technology platform, and they may not also be very comfortable in the language. How do I make sure I provide that and I can connect from wherever it is possible? So we do have a three-way facility where the caregiver can join the person who's also the patient along with the doctor to figure out what is going on over here and provide what is in their best interest. We are also coming up with a chatbot which can help save the time that you may be going through to address very frequent queries that your patients may have, which would helpfully save you your time and give you a better way by which you can focus on what's more important rather than things which are more mundane. Shrishi, the next slide, please. So just the last couple of slides as I'm coming to an end. We did speak about this a little earlier. Setting up a virtual clinic is relatively easy. From a technology viewpoint, it's hardly anything. But there is a whole change management required. Patients are still not very comfortable coming. How do I tell patients that I'm now available to consult virtually? What we started providing as a service, and many of the doctors asked us this, is to provide ways by which they can reach out to their patients. And this comes currently complementary to doctors who are taking up Connect to Clinic. So you do have a complimentary e-card, banners, there are standees put up at the clinic. On each of the prescriptions, you can get a small sticker which you can put on saying that you are available to consult online, and that is the virtual link that you have. You can have personalized posters being put up. You have support in terms of training being provided to your support staff at the clinic. So while you are consulting a patient in your clinic, your support staff can educate patients that this is something that's available. So if they so feel like, they can choose to do an online consultation with you as well. There is also a SMS service that doctors can send out to their existing patient base, and we can enable that to happen for you. Similarly, we can help you build a customized Facebook banner to show that you are present on a virtual clinic platform through Connect to Clinic, and we are able to kind of take that. So these are some of the things that we believe are equally important to drive in the offline world to make sure that people get to be aware that you have a virtual presence and your patients take the most benefit of the virtual clinic that you have set up for yourself. Shrishi, the last slide, please. Now, a couple of the things that we started out, we did not have an app, and we still have two ways by which patients can kind of come on. Some of the doctors and patients that we have seen are not very comfortable taking an app on. They would just prefer to go on a web-based browser and enter the browser link over there and do the consultation or do whatever is the kind of thing they want to do on Connect to Clinic. That option does exist. But we also have an application both on Android and iOS. The advantage of the app, of course, is that you get all the updates that keep happening. And like I was mentioning, every 3 to 4 weeks, you get constant updates that keeps going on. And you also have a way by which now it is just there. You don't need to remember the URL, and you can just directly do it through the app as well. So broadly, that's what I had. Shrishti, I'm going to leave it with this. And thank you all for your attention. I do urge if you could take a look at the Connect to Clinic platform. We'd be very happy to have your feedback, things that you think we can work on further, and how we can make this platform even more engaging and more beneficial for you. Thank you so much, Dr. Agarwal. Back to you, sir.
Thank you, Ganesh, for a beautiful and elaborative discussion on a difficult subject, made very, very, very easy. Now we now shift to the panel discussion. So I'll request Shrishti to have everybody spotlighted on the panel. And we have two panels, but I'll include one panel and one question answer. I will request Ganesh to also stay here. I'm going to combine the two together.
Sure.
So because we are already quite late in our program. So I'll incorporate the questions. So all the questions related to the technology can go to you
Sure,
with
sir.
that. And if we have Jayant and Dr. Pinto, if they are also here, they can also be, if they are here, I would like them also to be there in case there are some questions from the audience, because I have a lot of questions from the people. So can I close the window? Can it be just a simple spotlight?
Yes, sir.
Yes. So Dr. Ketan Mehta is not here. Bring him down. So I have Dr. Pinto. I have, let me introduce other panelists. I have with me Dr. Aditya Chauti. He is an MBBS JJM Medical College, Devanagari. And he is MD with the Institute of Medical Sciences, Bangalore, postgraduate diploma in diabetes from Johns Hopkins University, and a chief consultant and head of the Department of Diabetes Specialist Hospital, Bangalore, and many awards recipient. So welcome, Dr. Chauti. I have with me Professor L. Srinivasa Murthy. He is a senior consultant physician and diabetologist, Life Care Hospital and Research Center in Bangalore. Former consultant at Fortis Hospital, then Glenchley's Global Apollo Hospital, more than 20 years of experience, principal investigator in over 75 clinical trials. So looking like he's going to cross 99 like Sachin Tendulkar. Fellow of Royal College of Physicians, Indian College of Physicians, Society Executive Member of National RSSBI. Welcome.
Thank you, sir. Thank you.
I also have with me Professor Dr. Ketan K. Mehta. He is at Indian Heart Institute, Suchak Hospital, Nama Hospital, Lifeline Medicare Hospital, editorial board member of Journal of Medical Nutrition and Nutraceuticals, President MMA, Secretary, Joint Secretary, Treasurer, Secretary, Treasurer, Vice President, IMA Maharashtra State, and whatnot. Convener of NatCon of 2017. Welcome, Ketan.
Thank you, sir. Thank you, sir.
I also have with me Dr. Verma, and that is Abhyudaya Verma. He is MD, DNB from Hyderabad. He's a fellow of American College of Endocrinology, consultant endocrinologist from Indore initially, over 220 international and national publication in index journals, and reviewer of many journals and internationally and nationally recognized, currently in Hyderabad. And the rest have already been introduced. So thank you, everybody, all my fellow colleagues who are watching this program. I'm seeing a large number of questions. So I'll start my game, my first ball with Ganesh. What is this HIPAA? All the people have been talking about HIPAA compliance. Why it is important?
So thank you for the question, Dr. Agarwal. So HIPAA essentially is an international standard which kind of gives what is the way in which you have, so in essence, it is the Health Insurance Portability and Accountability Act, which essentially requires that there are regulations that protect the privacy and the security of health information. So it is extremely important, and given that we have enough amount of medical legal cases to talk about how the privacy and security is protected, HIPAA becomes essential to provide the right framework to ensure that you have the right level of encryption to make sure that data is secure and is visible only to the doctor and the patient, and applicable privacy laws are taken into account. So that's where it really holds, Dr. Agarwal.
So Dr. Ketan Mehta, when I was the president in the Secretary General of IMA,
Yeah.
we came out a telemedicine guidelines
Yes.
at IMA, and we were the first one to bring telemedicine guidelines way back in 2014, which were guidelines for our doctors. And we brought out a concept of personal protected information. That means the information which cannot be shared with anybody else. That means even a patient's wife cannot have personal care of the husband without husband's permission. And there we defined the patient's name, where we defined the patient's this bank account number, his sickness, his disease, his. So if you see the Harshad Mehta case, there's a insider news. Insider news is कि मेरा इस patient का, if you leak an information that he is being diagnosed with Hodgkin's lymphoma, and if it goes to the public, the market crashes. And you have seen our late Madam Indira Gandhi's death was declared hours later because they didn't want riots to happen on that particular instance. So leaking of a personal information, specifically for a person who is a diabetologist and a cardiologist, because the patients of diabetology and cardiology are all the ones who are pot belly obesity, and they are the people who are the key persons in the society, multi-billion and multi-billionaires. And if their information is leaked, you lose your business. You lose, as a doctor, you lose your business. And as the Medical Council of India ethics, we cannot leak our information. So therefore, we need a platform, the platform which is secure. Your comments, please, on this.
Sir, I fully agree with it, and that is why end-to-end encryption and what Mr. Ganesh has said, that HIPAA compliant platform, which is so much required, because we need to have those privacies, because today we know that data hacking, which is becoming such a common issue, especially be it in a defense level, be it in a political level, or be it in any other level. If that is happening with this, patients will not be comfortable giving out the data, and especially when we are dealing with somebody who doesn't want to disclose that they have a new onset of diabetes, or somebody who doesn't want to disclose about his coronary status, and if that is not maintained, people will not be compliant, and that is so much required over here. And I rightly said, as you have come out, that this was the IMED put the guidelines, and then we had subsequently Telemedicine Society of India has come out with their own guidelines also, and probably where we need to have the data encryption end to end, the safety, which is of utmost importance, sir. Thank you.
Dr. Aditya, do you have a secretary?
I do, sir. I have an assistant.
You have a secretary. And how often she uses your phone? When you say, take this phone, call this person, give it to me, or you say, kindly note down all the messages and pass it on to me.
So a bit of both. She helps me in keeping the tags and the patients, but mostly I take care of everything. Sir.
I'm just asking how often in a month you hand over your phone to your secretary.
Oh no, my phone does not go to my secretary.
Urgent call, for an urgent call. If you are busy in this seminar and there is a call, you say, kindly take the message.
Okay. So she has her own phone, sir, a number which is tagged to mine. So
phone
all of it goes there.
How often you share your phone?
at least once a day.
Once a day.
Yes.
Everybody, this will be true for everybody. Okay.
I'm hoping so.
That's sufficient for her to get a bribe and take away any special message on a WhatsApp consultation and become an insider informer and make billions of dollars on the share market. If you happen to see a patient like Birlas or Tatas or Ambani's giving a teleconsultation,
yes,
and if she takes away the consultation prescription pad,
yes,
and she can make billions, not millions.
Yes.
Therefore, WhatsApp consultation is not reliable.
Absolutely, sir.
What I'm only trying to say is WhatsApp, telephone, SMS, emails are not reliable, because even your emails can be hacked.
Yes.
So you need an external port, whichever it is.
Yes.
They are also the only risk is that tomorrow Connect to the clinic will say that I will sell my property to somebody in Singapore. That the whole platform is taken over by somebody. Fortunately, it is being backed by Indian pharmaceutical companies, so that possibility is also not there.
Yes.
Otherwise, when you choose a platform, you always have a risk that the whole platform is sold to somebody else. Then where is the agreement? Where is the agreement? The people who have an agreement, they have disappeared from that. So here, because a pharmaceutical is in the background, the risk is also not there. Aditya, comment on this.
Yes, absolutely, sir. I think we do need to keep our consultations private, as it is, as you mentioned, in the Indian Association Code of Ethics as well. I completely agree with you on this. And I think being backed up by such a big company, I mean, at least we do feel safe on that front as well. And I have been using Connect to Clinic quite vibrantly. And I'm quite happy with the way things are shaping out and working, sir.
Dr. Verma, you practice where?
Sir, I'm practicing in Indore, sir, Madhya Pradesh.
That was till 1 minute back. So this is now 5 o'clock, 15 minutes. At 5:14, you were practicing in Indore. Now you are practicing
Virtually.
globally.
Globally.
Globally. Why
Yes.
should you say that I'm practicing in Indore? Your answer
Yes,
has
sir.
to be, how does it matter to the patient? Where are you?
Correct, sir.
How is patient concerned where you are sitting? You may be
Correct.
holidaying in Goa.
Correct.
Patient doesn't know. So your virtual clinic, on your virtual clinic, now you are a global physician. Why you have to say I am practicing in Indore, or I am in Hyderabad, or I am in Calcutta, or I am in Mumbai? I am a global physician available all over. Sooner or later, there will be a conflict, and that conflict will be that state medical councils will have to modify their, because now question comes is of a jurisdiction, because you need to have a state medical registration required where you practice. But with the Telemedicine Act, that becomes defunct as on today. So for all of us are a doctors, global physicians. So congratulations,
Excellent.
Dr. Verma, for
Thank
now
you.
being a global physician.
Thank you, sir. And thank you, C2C also. Sir, definitely it has helped me a lot. Now, at least I'm able to go home early, eat my dinner at home, and then maybe after 8:30, take on my consultations. And I think patients are also quite happy, sir, because they also finish their work, they also finish their shops or whatever. And then in the leisure time, including holidays also, when usually I refuse them uh, for consultations physically, they are happy, and I am also happy that they, as and you told a very good thing about Goa. So this has given me another good idea that if I am holidaying away also somewhere, I can definitely continue my consultations.
Yeah, your virtual clinic can continue. There's no holiday for a virtual clinic. You don't have to inform that patient that I'm going away. They don't even come to know. They will not even come to know where you are. Wherever you are, you can participate in that.
Yes.
With that.
Yes.
So coming back to Dr. Murthy, that people from Pakistan, Bangladesh, Nepal, NRIs from all over the world want to consult you. So what's the idea? Why can't we practice all over the world? When it comes to, we can take permission from RBI. We can take permission from RBI. The money can come to us as a consultation, or you can take them as donations. Some doctors told me the jurisdiction, where the jurisdiction will be. You can sign an agreement with them that we will not be liable in your country if you want to do a consultation with us, or you can take the money in a donation. So now with a click of a button, you are available to all the NRIs in the world. Forget about, I mean, I'm not talking about the other people, even all the NRIs will like, because two things have happened. CHINA is not reliable, and USA is not the best. This corona has taught us USA is not the best. And if you are the best, and if we are the best, this vaccine has taught us. So all of us now stop competing with each other. And we need to connect to everybody. When you talk about C2C, connect whom? Everybody globally. Dr. Murthy.
Right, sir. Though I would love to be called as a global physician, but my Telemedicine Act, published on March 25th, 2020, does not allow me to consult across borders. So though I would like to, but officially I cannot consult anybody outside India.
Yes, for charging money. But you can still take donations and do that. In the COVID era, everybody from across the world is looking for India. So whether Telemedicine Act allows it or not, the act has to change if you really want to compete the global sciences. I agree with you. What you are saying is, you can start your practice by doing charity for international. Build up your name. We need to build up your name. Now, Telemedicine Act may not allow us, but Telemedicine Act allows us with a, say for example, if I want to consult a doctor in US, okay, so we have been taking RBI permissions and sending the money. My patients have been doing that for years together. They have been taking permission from the RBI to transfer the money, that this is a consult on a case-to-case basis. On a case-to-case basis, there is no problem for that. Go ahead, Dr. Murthy.
Sir, I don't think we can collect it in the form of charity. Still, you are liable to the land of law.
Don't charge
Even
it.
if you're doing a free consultation during your course within India also, and if something goes wrong to the patient, you are liable. Just because you did not collect your fees, you don't go out of this law clutches. So
I agree, but okay. I take it other way around. It will explore possibilities for us to become global physicians.
Fair enough. That is there.
This
That I'm doing
telemedicine,
through clinical trials.
Ultimately, yes, we are in a phase of a clinical track. Take
Clinical trials.
Off-label use.
Yes.
So you take a off-label use and do it.
Correct.
Off-label use. What is off-label use is that there is a clause in USA, and that clause is you can sign your own agreement with the patient about compensation. So if you sign a clause with the patient with your compensation, that my compensation will not be so much more than this, as government has done it for tubectomy failure for 30,000 rupees. The government has done it that in a tubectomy failure, the only compensation will be 30,000. Get it done or don't get it done. So you can also sign those off-label agreements between the patient and you. Then you are out of that Telemedicine Act with that. Ganesh, you want to comment on that? It's an interesting discussion.
No, Doctor, I think it's been laid out very, very nicely. I do believe that, and the government has made changes on the Telemedicine Act with the addendums that came out in March and in April and in May. But as we are seeing it now, definitely, I think, and you pointed out very correctly, I think Indian physicians and Indian HCPs are being seen across the globe. So there is a reason for us to start looking at how can we make changes to this part which does not allow people to use telemedicine globally, not just for NRIs. I would argue even for people who are of any country and so on where they are. But there does need to be a change coming over there, Dr. Agarwal. And I'm sure
challenge in the Supreme Court. If it is challenged in the Supreme Court, it will lose its existence. The reason being, we are calling all the international people on Zoom as a faculty.
Absolutely.
They are giving me consultations. Yeah. As a doctor, when I ask them what should I do in such a case, they are giving consultations to me as a doctor to doctor.
Sure.
So I think I will take it from Dr. Murthy, build it up, and if required, even file a PIL to see to it that Dr. Murthy becomes a global physician. And I will make sure that he is the first one to become the global physician in the world with that. Dr. Chowty, coming back to our main subject, come back to each one of you, give your personal experiences about C2C or any other platform. A minute each.
Yes. So I think using C2C is not going to be confined only to the COVID era. I have seen a number of patients, especially the cardiodiabetic group of patients, the metabolic diseases, they're getting very comfortable having consultations over the online platforms. They're simple funda to show you my sugars or to show you my reports. I don't need to come and see a doctor. So I think the follow-ups are becoming more regular. I think compliance is increasing, and I think because of the frequent in-house visits, they used to avoid it. I think, sir, it's going to go beyond the COVID era, and it's going to become a norm, is what I'm looking at, sir. And I think C2C is a wonderful platform for such a situation, and I think it's enjoyable on both the patients and the consultants' side. Is what my views are, sir, on this.
Dr. Murthy.
Sir, I have been using it from 2012, the online platform, but the COVID has given the speed or the acceleration it was required. Because of my research background, we need to have a EMR. So I have this from last 8 years, and definitely the compliance is much better, as Aditya was pointing out, because this is what we see in research, where there is something called as the telephonic visits in the clinical trials, and that is where we have this, because there are a lot of glucometers now which are connected, linked to our EMR, and we can see their 7-point profile, 9-point profile, and titrate the dosage, especially in an insulin setup, basal bolus regimen. It's very, very convenient. I think that is something which is very great. And I'm so serious now that I want to continue the telemedicine in the second half, and first half is only my darshan will be there for the practice, during the practice. I think that is what it has given me, the convenience and acceptance among the patients. I mean, that's something really amazing, because in Bangalore, to travel from one place to another place, which is about 5 kilometers, you just take 45 minutes. 5 kilometers, 45 minutes. And that is what we are famous for. And I practice in the north of the Bangalore, and somebody from south who's a bedridden lady, I can consult. And that's something which is never going to happen when there is a physical consultation, because to travel from south to north Bangalore, it takes about 2 hours in a peak hour. And that is something which has made me convenient. And I'm becoming global locally, I would say. Definitely within Bangalore, I'm becoming global locally.
Absolutely. So coming back to one more thing that I'm talking about a couple of years back, when I was attached to a prime hospital in Delhi, where I worked for more than 35 years. When I was practicing in their private OPD, so they came out with a new rule that you will not be allowed to see patients outside the hospital practice. And you have to see your patients only in the hospital. Initially, the fee was mine, but suddenly they made 25% hospital will charge. That means if you see a patient, if your fee is 1,000, 250 rupees will be taken by the hospital for providing you the space. So A, you cannot practice outside. B, you have to practice here. Bring your patients. If you are not bringing your patients, you are charge sheeted. That you are only eating the hospital's patient. You are not bringing your patients. And ultimately, this was one of the reasons I left that corporate hospital's practice. 25% is a lot of money. For this, you have to spend a petrol, go to the hospital, spend a time there, and if there is no patient, you sit there for 2 hours for seeing one patient. You can't do anything else also. And your data is with the hospital, at the mercy of the hospital. And when I left the hospital, I could not get my data back, but that data belonged to the hospital. So you need an independent platform to work, which is not charging 25% of the money. So the clinical platforms now are charging from 6% to 10% to 12%. I've been given to understand C2C is charging 6%, which is much lower than the cost of your secretary. Ketan.
Yes, sir. Totally agree, sir. Which is now the current state, even in the major metro cities and all, the corporate hospitals are charging a boom, and they take away, where depending on the locality or depending on the corporate setup, they are charging up to 30%. That is what it is there. I know 1 or 2 hospitals, corporate centers in Mumbai charging 30%. So, as a consultant, you feel it is all your efforts, and you have to just pay for it, which is not correct. So where here, when you can save on the transport, when you can save on the extra time and do on the virtual platform, and where only that 6%, and that also the provision is there, whether you want to pay from the pocket, or the C2C is even offering that whether you want to get it charged from the patient. So still that option is also available. So consultant has got a liberty to decide whether that full 100% should come to him, or those additional 6% should be charged from the patient. So I think it's a fantastic platform. In fact, sir, I would share with you that when the program this was built, Mr. Ganesh would know, I was a part of the team of first 20 people across India who were part of formulating and giving the ideas. And we have seen over a period of time, this baby has grown to such a fantastic outcome with beyond limitation.
Dr. Mehta, your training was the one which has helped this baby to grow. So thank you for that, sir.
My pleasure.
I never
So
realized,
you're a shareholder.
Yeah.
I
hope.
I never realized Ketan is also practicing pediatrics. So can I have Dr. Verma's view on this?
Yes, sir. Very nice platform, and thank you. I have been using these telemedicine platforms. I don't want to name them, but they were not that doctor friendly. And we know most of these were basically meant for patients priority. They never gave doctors a priority. And basically, like sir was talking about the corporates, I would say here these platforms, they were exploiting uh, us doctors for telemedicine. And as Mehta sir said, even I think I was also amongst the early people who were contacted regarding the C2C platform. And definitely, the whole team has worked a lot regarding this from scratch. I think they have become the best of the platforms I have seen till now. And lot of things means basically they have done so many changes. They have improvised everything, taking from the patient's detail, the including like uploading the images also, lot of things including the digital our prescriptions. So lot of things they have done. I think my practice, frankly speaking, I was planning to expand my clinic, but now I feel that I don't need to expand my clinic if have a single room. And most of my patients, if they come on C2C, I would be happy not to spend money on my clinic. I can save that money and have a C2C consultation lot of my patients. Second thing, as we already know about the condition of India, lot of our patients, they come from remote places, especially I would say about Madhya Pradesh. Lot of my patients, they come from nearby villages, and with them lot of attenders also come, at least 2 or 3 attenders, transportation problem. But now people are happy with me. As an endocrinologist, we see insulin patients regularly for SMBG and other things. Now, with all these facilities, we have a good follow-up with these patients that has improvised the blood sugar control. It has reduced the cost of transportation. And frankly, I would say one of my biggest headache, when a lot of my patients, they used to literally fight for the place to show me or to have a consult. So this is like it was kind of a big headache, and that headache is now over, because those patients, they need not catch a train or bus at a specific time. They need not wait for my consultation. And lot of, I would say, more than my city patients, my village remote area patients are having benefit of this. So thank you, C2C. And I would, in the end, I would like to thank your team also. I had Mr. Shekhar Shah with me. He helped me a lot throughout, like maybe like from 6-7 months. He's continuously in touch. Yesterday night also I had a problem with C2C consult, but he made it within 5 minutes ready for me to use. Thank you.
Thank you, Dr. Verma. And because the time is less, I'll go for a quick fire. If Dr. Panda, are you there? Professor Dr. J.N. Panda? I'd like to take now one-liner messages from each one of you. The key message, make sure that doesn't duplicate. And then our team, along with Elkem, will make it into a short video as a quick message. That can be sent to all the doctors in the country. Dr. Panda, you have gone? No, I think he has gone. So let's start from Dr. Murthy. Key message.
I think telemedicine platforms are convenient and comfortable at your home, at your clinic. So use it as much as possible within the purview of the law.
Dr. Verma?
Telemedicine, I think, is the biggest boon for medicine, and this saves a lot of time for a physician and patients also, and improve the quality of care.
Dr. Aditya?
I think online consultation is a fantastic tool to develop a good interpersonal communication with your patients. Please use it wisely.
Dr. Ketan?
Specifically, I would mention about the C2C platform, which is an international compliance standard, having a total medico-legally safe from the doctor's point of view, and also the specific point of extending the slot on the fly, which is a fantastic feature. So I would strongly recommend to use C2C.
Ganesh?
A simple, secure telehealth platform is what C2C endeavors to be. It is doctor-centric, and it is something that will help your patients and your practice grow. So please do make the most of it, and we are there to support you and make sure you're able to get the best out of it.
When the name came Facebook, if you were seeing the faces of each other, it was like a book. So the name was very, very, very clearly taken up by the society. And then everybody, when they were chatting, they used to say WhatsApp. It was up, not app. This became WhatsApp as a name because everybody used to say WhatsApp, what's new? The common name was WhatsApp, from where it became WhatsApp. And now you are connecting a patient and a doctor. So basically, it is a C2C where it's easier way to remember. It's a communication or a connection between patient and doctor. So this is whether at national, whether at your house, at 24/7, wherever you are, whether you are holidaying or not. So therefore, one can remember C2C. Remember, we have other options available also. We have telephone, WhatsApp. Don't discard them because they are for emergency. When you don't have a connection, when it is a real dire emergency, then follow the Supreme Court guideline. Don't miss out your patient just because he is not on any platform. Look after all the emergencies and then guide them to come back to your recognized platform. That's all for today. Let me thank all my panelists and speakers, Dr. Panda, Dr. Pinto, Ganesh, and all my panelists, Dr. Murthy, Dr. Verma, Dr. Aditya,
Thank you,
and
sir.
Dr. Mehta to be here with us. Keep watching us. Keep connected with us. We will be back with some other videos. All the times, all of us are available, and our job is to educate you, to impart knowledge to you. Remember, day after tomorrow is Christmas. If you're going to send a cake to anybody, the first of all is going to say, keep it outside, let him stay there for 15-20 minutes to get rid of the virus. But if you send them a video as a link and write down Merry Christmas, he'll always have a positive thought. If you like this video, right away, send the click and write down Merry Christmas and Happy New Year's to everybody. And in any way, Merry Christmas to all of you here and to all my colleagues who are watching this program. Thank you.
Merry Christmas.
Merry Christmas.
Thank you, sir.
Happy New
Stay
Year.
safe.
Keep watching us.
Take care.
Keep watching us. We will come back with latest information. And yes, don't be afraid of this new strain of the virus. We don't know. We may be already heading towards a herd immunity. But yes, telemedicine is going to stay, and stay. Thank you.
Thank you.
Thank you, sir.